I want to just touch a little bit on some of the novel agents that we're going to be talking about in a little bit more detail, but the thought of bringing them into upfront therapy with the idea of being able to lessen some of the myelosuppressive chemotherapy that we have to give. And there were some presentations at the American Society of Hematology meeting that were and the MD Anderson group tends to be in the, I'll say, the forefront of this area. They had some presentations here using inotuzumab ozogamycin. This is a monoclonal CD22 antibody linked to a cytotoxic agent, calicheamycin, and combining that with low-dose chemotherapy, their mini hyper-CVAD or mini CVD regimen, and showing some encouraging results with that. What are some of your thoughts, Bijal, about that?
I think this is the future. We have to determine how to integrate these novel agents into our frontline therapeutic regimens, not just for the elderly. I think it's a place to start, meaning I also will tell you, as much as I want to say this a little bit differently, I want every person I'm seeing to be cured, and I want to maximize their likelihood of cure. But for the average adult, we're still batting around 40 to 50% long-term cure rates, and I would argue that's not success. And understanding whether we integrate inotuzumab onto a full chemotherapeutic backbone or onto dose-modified chemotherapeutic backbones is one that we'll continue to explore. But the activity we're seeing in the elderly population and in the young adult and in the other populations with INO and blin combinations, very, very encouraging. Mm-hmm. We do have to be wary of toxicity with inotuzumab. And while it's very encouraging, we do have to recognize that it can induce cytopenias. There is a broader effect on the bone marrow by putting calicheamycin, a bystander effect, I should say, by putting calicheamycin in the bone marrow. Thrombocytopenia is common, but neutropenia can also emerge, and infections can also emerge. And then, of course, we can't ignore the issue of hepatotoxicity. Both VOD and just generalized hepatotoxicity as we're delivering this calicheamycin based antibody, and important to stress that that's not just while we're giving the therapy, but something that may extend well beyond the time that we give this particular drug. So thinking about how we do transplant, when we do transplant, and by how I mean avoiding things like double alkylator transplants are incredibly important in this regards.
Mm-hmm. Thank you. Jay, could you comment about the trial you were involved with, the SWOG trial that was the intergroup trial where Dr. Advani utilized upfront blinatumomab in older patients with ALL, and what kind of results we saw with that?
So I think, as Dr. Bijal was saying, I think it's a very exciting time, and all of a sudden that we have a very effective therapy that we can use in older ALL patients. Before we used to get, if we were seeing 70-year-old patients and you pray they're pH positive, and if the pH minus, what options do we really have? A steroid vincristine, maybe some cytoxin induction therapy. But now we have an options of this new and then kind of novel and different mechanism of action. So I think there have been different approaches, and as kind of the Bijal was mentioning before and you're alluding to, inotuzumab CD22 targeted the drug conjugate in combination with the less dose intense chemotherapy. The other approach that the group has taken is using looking at blinatumomab, which is a bispecific T-cell engager targeting both CD3 and then CD19, so bringing the T-cells closer to the site of the B-cells and therefore generating the tumor eradication. So blinatumomab is approved and has been studied in relapsed refractory settings, but this is kind of the first time studying as a single standalone regimen, as a single agent, assessing the single agent activity and then the safety in older ALL patients greater than age 60. So these patients are receiving blinatumomab as, again, kind of single agent, first 1 or 2 cycles to assess the response. If they're in complete response, these patients went on to receive consolidation blinatumomab for 3 additional cycles, and then went on to receive a pump, kind of low-dose oral chemotherapy maintenance regimen for 2 or 3 years. So in this setting, I think this is a very novel approach and kind of the first taking, and then the response rates are certainly very, very encouraging. The CR rate that we are seeing, and this is early preliminary data that we are presenting at this year's ASH meeting, is about 65%. So in this age group that we're not, previously we probably estimated with the traditional chemotherapy about 20% or so. So this is an improvement, kind of CR, CRP, and a CRI, depending on their hematologic recovery of the blinatumomab. So the responses are very encouraging, and the toxicity also appears to be favorable. We do see some the similar side effects, the cytokine release syndrome, neurological toxicity, but not any more than what we are seeing in younger patients in relapse setting, and also very little grade 3 or 4, the toxicity that we really worry about. So it appears to be tolerable, inducing the better response rate than we were seeing before. Whether we can improve even further from the 65% to 90% to 100%, and this, I think that's kind of the area that we need to move on to. This was a very good first step as a kind of large effort by the intergroup to kind of study that, and I'm very excited to see kind of what will happen with this agent's incorporation by itself with other combinations.